I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. COVID has taken an unbelievable human toll. It's also resulted in huge economic losses. Who will pay the bill? This is the People's Pharmacy with Terry and Joe Graydon.
Dr. Elizabeth Rosenthal was an emergency physician before she became a journalist. She's now editor-in-chief at Kaiser Health News. She describes an eye-popping bill for a COVID test.
Most patients did not have to pay for their COVID care last year, but the government and insurance companies are now moving the goalposts.
Millions of people are suffering from long COVID. Who will pay for their treatment? And how much will it cost?
Coming up on the People's Pharmacy, learn why our health care costs are so high.
In the People's Pharmacy Health Headlines, the Food and Drug Administration recently announced the recall of the blood pressure medicine irbesartan. All batches of this blood pressure medicine made by the Indian drug company Lupin are being pulled off pharmacy shelves. That also includes irbesartan and hydrochlorothiazide pills. Irbesartan is referred to as an angiotensin receptor blocker, or ARB for short. The problem involves a contaminant called N-nitroso-irbesartan. Nitroso compounds are considered probable carcinogens. This is not the first time ARBs have been recalled because of contamination. Blood pressure medications such as valsartan and losartan have been recalled because of other nitrosamine impurities, such as N-nitroso-dimethylamine, or NDMA. Millions of pills had to be destroyed because of this probable carcinogen. Last summer, Health Canada recalled batches of valsartan, losartan, and irbesartan because of azido impurities. Generic drug companies caught up in the recall included Teva, Sandoz, and Sanofi.
Drug recalls have not been limited to blood pressure medications. Over the summer, Pfizer announced that it was suspending worldwide distribution of the stop-smoking drug Chantix. That was because of high levels of nitrosamine contamination. All lots of Chantix distributed between May 2019 and September 2021 are now being recalled. The FDA is not advising patients to stop taking Chantix, however. Instead, the agency advises people taking the stop-smoking medication to consult their healthcare provider and ask about alternative approaches for quitting smoking.
Another medication that has disappeared from pharmacy shelves because of contamination with a probable carcinogen is ranitidine. It was once sold under the brand name Zantac. Ranitidine was found to have excess levels of NDMA, the same nitrosamine found in tainted blood pressure medications such as valsartan and losartan. When ranitidine was stored at high temperature or left for a long time in warehouses or in shelves, NDMA formed. Batches of another medication, metformin, were also found to contain NDMA. It's the most widely prescribed diabetes drug in the world. In theory, most metformin being sold today is no longer contaminated, and Zantac was reformulated with a different acid-suppressing drug. Zantac 360 now contains famotidine instead of ranitidine.
When you slather sunscreen on your skin, you expect it to protect you from damaging ultraviolet light while you're outside working or having fun. New research suggests, however, that testing sunscreen ingredients individually, as is currently done, may not tell the whole story. The scientists found that zinc oxide, which is a safe and effective UV filter on its own, can speed the degradation of avobenzone, a compound used to provide protection from UVA. As a result, it loses effectiveness rapidly. According to the scientists, this study found that combining sunscreen active ingredients, which are safe on their own, can result in decreased mixture safety following UV radiation.
The FDA is poised to revolutionize the hearing aid marketplace. The agency has proposed new rules that would allow hearing aids to be sold over the counter directly to consumers. Devices could be sold online without the involvement of an audiologist or an otolaryngologist. This is likely to increase availability and affordability. Tens of millions of Americans suffer from mild to moderate hearing loss. Until now, many did not consider hearing aids because they are so expensive. As a result, only about 20% of those who could benefit actually use listening assistance devices. The proposed rule should make it far easier for people to find and afford appropriate hearing aids.
Older people and those living in residential care facilities are at greater risk for falls and fractures. New research suggests that when these individuals get more dairy products such as milk, yogurt, and cheese in their diets, they're less susceptible to broken bones. Those who got dairy had a 33% lower risk of fractures overall and 46% lower risk of hip fractures. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. You've probably heard the expression, everybody complains about the weather, but nobody does anything about it. The same could be said about the high cost of health care. Americans spend more than anyone else in the world, and yet we don't live longer or healthier lives. How will the cost of COVID affect the healthcare system?
To learn more about why our healthcare costs are so high and whether COVID will break the bank, we turn to Dr. Elizabeth Rosenthal. She is editor-in-chief of Kaiser Health News. She joined the organization in 2016 after 22 years with the New York Times. Her book is An American Sickness: How Healthcare Became Big Business and How You Can Take It Back.
Welcome back to the People's Pharmacy, Dr. Elizabeth Rosenthal.
Oh, thanks for having me again.
Dr. Rosenthal, during much of the pandemic, the costs of COVID treatment were covered either by insurance or by the government. I mean, somebody else was paying. And that included if you had to go to the hospital, if you had to be in the ICU for a week or a month. But now insurers are charging copays and deductibles. What changed?
Well, I think one of the things that changed importantly was that we now have a vaccine. So, insurers were under some pressure, and rightly so, to cover these charges at no cost to patients when there wasn't a way to avoid getting COVID. Now that there is, I think they're like, well, and companies too, why should we be holding the bag when you're making a choice that leaves you vulnerable?
Now, the vaccine does not cost people, is that correct?
It generally, as long as we're in a public health emergency, there will be no out-of-pocket expense. That's true. Although we are now seeing sometimes, for example, if you do not get vaccinated and you need a COVID test for a return to work, you may see some copays imposed there, and for the same reason. So I do think, yes, the insurers stepped up and did the right thing in saying we're not going to hold patients responsible for these payments, but the backdrop has changed now, and I think we're going to see that going away. We did just yesterday a bill of the month about a patient who was charged $54,000 for an out-of-network COVID test. And what we see happening, which is equally distressing on the pricing side, is that when the government or insurers say there's going to be no out-of-pocket expense for patients, what does a system that works like a market do? It says, Yahoo, patients aren't going to care how much we charge, so we're just going to charge a lot. So we featured a guy who was charged $54,000 for a COVID test. His insurer paid $17,000, and he even though he had no out-of-pocket expense, he went back to the insurer and to the hospital system and said, this is nuts. And thankfully, he was an activist patient and got the bill knocked down. But I think, we're losing tolerance now with some of the folks who don't want to get vaccinated, some of the prices that's imposing and costs that's imposing on the entire system and the rest of us.
But Dr. Rosenthal, even people who have been vaccinated may need COVID tests from time to time. $54,000, where does that come from?
Well, that comes from a system where, where, as they say, if patients have no skin in the game, and it just says on your insurance explanation of benefits, we paid $54,000 or $17,000. And if you see that line at the end that says what you owe now, zero, you may look at that page and go, well, that's bonkers, but it's not coming out of my wallet. So why do I care? But of course, the fact is that if my company is ever paying $17,000 or $54,000 for a COVID test, my insurance premiums are going to go up next year. So, it really isn't no cost.
Well, Dr. Rosenthal, let's go back to what happens when someone ends up in the hospital with COVID-19. Now, some of those folks did get vaccinated. They've had breakthrough infections, and they still may be spending a few days or even a week or two in the hospital. And for the folks who are unvaccinated, some of them are going to end up in the ICU. And you know far better than we do what it would cost to spend a week or 2 or 6 in the intensive care unit. It'll break the bank.
Sure. I mean, early on in the pandemic, before there were vaccines, again, we looked at some of these bills. These are $500,000 hospital bills if you end up in the ICU. If you need that ECMO machine, which oxygenates your blood, you're talking north of $1 million probably. So these are very, very, very expensive hospitalizations. And even more so because that kind of intensive resource is limited because we don't normally need it. Not only are they very expensive, but you end up saying which patient should be allowed to go on ECMO, a kind of rationing of care, which is just horrible. So yes, there are breakthrough infections, and yes, some people with breakthrough infections end up in the hospital, particularly if they're older or have underlying immune problems. But they tend to be much less acute, hospitalizations, a few days on a floor with oxygen rather than 2 months in an ICU and ending up needing a lung transplant. So there's just a level of cost that is not comparable.
But I'm suspecting that there are a lot of people who are going to be facing medical bills over the course of the next several weeks, months, and perhaps even years that are going to lead to bankruptcies.
Well, I mean, this is, I always say that COVID and the pandemic has been a stress test to our system, and it's exposed all its long-standing vulnerabilities, right, and problems for patients that if you are unlucky enough to get a bad disease, and in this case, at this moment, COVID is candidate number 1 probably, you can be bankrupted because our hospital system charges so much for care, and our insurance system, even for those of us lucky enough to have good insurance, involves increasing levels of copays, higher deductibles, surprise out-of-network bills. And so there are just a million ways to be caught off guard in this system. And with a disease like COVID, you need lots of different types of interventions, some of which may be covered partially, covered with a copay, covered with coinsurance, on and on and on and on. So yes, there will be big bills. And I tried to point this out in an op-ed I did for the New York Times with a former colleague of mine that if you're not worried about getting sick from COVID and the after effects of that, you should think about the cost that you may incur in the process of getting treated. And the good news now is that there are better treatments, right? That even if you don't get vaccinated, there are other kinds of things like monoclonals and antivirals coming down the pike. But it's all at a big cost. And, if you don't have $5,000, $8,000 in your bank account, or if you're uninsured, it will massively impact your family, not maybe in terms of health, but in terms of financial health.
Dr. Rosenthal, we understand that the Kaiser Family Foundation recently conducted a survey on who is most affected by the financial burden of COVID. Would you tell us about that, please?
Well, it tends to be the poor, diverse populations, the un- and underinsured. I don't honestly remember the exact statistics, sorry, but it's the people who are suffering in our medical system generally.
Dr. Rosenthal, you've talked a lot over the years about the variety of prices for the same kind of procedure. And I'm guessing that will also be true when it comes to COVID, that, a patient who is treated in New York City may have one kind of a bill for COVID, but somebody treated in a small town in Nebraska might get a completely different kind of bill. I'm just wondering if you could explain this incredible price difference from one hospital to another.
I can explain it, but it doesn't make sense rationally. Sure, let's just look at something as simple as a COVID PCR test, that swab deep up the nose that everyone is familiar with now. Medicare pays $100 for that about. But as I said, a freestanding emergency room in Texas charged $57,000. So can you imagine if your a carton of milk had that kind of price range? Everyone would go nuts. And it's basically, Medicare actually takes into account what it thinks a test should cost, what's, a reasonable return. Now, pharmaceutical companies and hospitals may think that return is too stingy for their taste because they have shareholders and boards, of course. The high-end bills are just what the market will bear. So we did find, even again for that simple PCR test, the Kaiser Family Foundation found that 1 in 5 are over $300. So 3 times what Medicare would pay.
You're listening to Dr. Elizabeth Rosenthal. She practiced emergency medicine in New York City before becoming a journalist for the New York Times. She's now editor-in-chief of Kaiser Health News and author of An American Sickness, How Healthcare Became Big Business and How You Can Take It Back.
After the break, find out how hospitals code their bills for COVID care.
Hospital billing codes are hard to understand. Why do they matter?
Who will be paying for COVID care when someone needs hospitalization now?
We'll also discuss the likely impact on our healthcare system.
How do healthcare costs in the U.S. compare to those in other countries?
Are we getting our money's worth?
With the price of some prescriptions skyrocketing, how many Americans are skipping their drugs because they can't afford them?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This podcast is made possible in part by CocoVia, maker of high-potency cocoflavanol supplements. Cocoflavanols are among the most well-studied plant-based nutrients, backed by 20 years of scientific research.
CocoVia Cardio Health is available in capsules or powder, providing 500 milligrams of cocoflavanols daily. This supports better blood flow and vascular performance.
CocoVia also offers Memory Plus, supplements with 750 milligrams of cocoflavanols. This product is backed by 4 different clinical studies demonstrating significant improvement in several aspects of memory.
CocoaVia flavanols are derived from real cocoa beans. They offer you all the benefits of chocolate without the sugar. More information at cocoavia.com. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
The People's Pharmacy is brought to you in part by Kaya Biotics, organic probiotic products developed in Germany and made in the USA. KAYABiotics.com.
Also by CocoaVia, now offering its Cardio Health Powder with 500 milligrams of cocoa flavanols. More information at cocoavia.com.
Today, we're trying to understand why our healthcare costs are so high.
Our guest is Dr. Elizabeth Rosenthal, editor-in-chief of Kaiser Health News. She practiced emergency medicine in New York City before becoming a journalist for the New York Times. Her expertise includes environment and healthcare. Dr. Rosenthal's book is An American Sickness: How Healthcare Became Big Business and How You Can Take It Back.
Dr. Rosenthal, we're going to take a risk and get kind of technical here. As we understand it, a good part of what explains a hospital bill has to do with the code. Now, codes are very technical, and coding for COVID care has changed quite a bit since the pandemic began. Why do codes matter?
Well, codes matter because the code determines the price that a hospital will get paid for a procedure under Medicare and by different insurers, although the commercial insurers' rates will be much higher than the Medicare rate. And conversely, the Medicaid rate will be quite a bit lower often than the Medicare rate. So, there's how you code a hospital stay, what you code for, and there are huge departments that are in charge of this, determines how much you're likely to get paid. So there's incredible incentive to what we call upcode, meaning, okay, I had a 15-minute ER visit, but no one was here, no one saw what happened in the room. I could code that as level 3, but if I'm a hospital billing department, let me try level 4. No one knows how long that actually took or what I did in there or what the doctor did in there. Likewise, it's very tempting for people trying to maximize revenue, and here I mean, providers, to code for everything and anything. We got a bill recently where there was a code for a 15-minute walk for 2 days during a hip replacement. Now, what was that walk? Was that a nurse walking the patient to the bathroom? Was it a physical therapy session? The patient has no idea. All he knows is there is a code for a 15-minute walk. So what we find is both upcoding and what we call unbundling, where, 30 years ago, when I was a practicing doctor, I came with the emergency room where I was an ER doctor. Now we're going to unbundle that. The doctor's fee is different. The transport fee may be different. There's a fee for checking your pulse oximetry. There's a fee for transporting you. And it's as if every little item, you see it on airplanes too, suddenly you have to pay for baggage or an aisle seat or an exit row. Unbundling is a great way to make more money. It's probably not a great way to run a health system where you want care to be comprehensive and inclusive.
Dr. Rosenthal, I'd like to go back for a moment to COVID and talk a little bit about long COVID.
Sure.
Because we're hearing that it could be anywhere from 10% to perhaps as many as 30% of the people, even those who have been, shall we say, just minor illness with COVID, or maybe even asymptomatic, a couple of months down the road, all of a sudden they're short of breath, they're incredibly tired, fatigued, they've got brain fog, on and on and on. And now if they go to their healthcare provider, all of a sudden now they have to go to a neurologist. they have to go to a pulmonologist, they have to go to a rheumatologist because their joints and their muscles hurt. So the bills post-COVID with this long COVID or long hauler problem could end up being astronomical. And again, I'm wondering, who's going to pay and what's the impact going to be on our healthcare system and, in fact, on insurance companies and ultimately our premiums?
Sure. I mean, this is a big problem. And, whenever people say to me, well, I'm in my 20s and I'm healthy, so I don't think it's so important to get vaccinated, or I'm not getting my teenage kid vaccinated because the disease isn't so bad in them. Long COVID can happen, as you said, after minor or asymptomatic infections. We still don't understand a whole lot about it, but it's clear it can persist for months. And remember, this is a wily virus that is neurotropic, meaning it affects not just the lungs and the respiratory system, but the nervous system as well. So that tail of COVID is a pretty serious thing. And, will people be able to get the care they need? Will they be able to afford it? It can end up being very, very pricey. And it's not like, it's a new and evolving, our understanding is evolving of this new virus. So it's not like, the neurologist down the block will have answers for you necessarily. You may have to end up at a specialty center. So this could be extremely expensive, as many chronic diseases are. And part of me is not that surprised that there is this thing called long COVID, because bad viruses have a long tail of effects. If you've had a really nasty bout of influenza that got into your lungs and got you pneumonia, it will take months to really fully recover and feel back to yourself. So this is not a, one and done thing like strep throat where you take your antibiotic and it's gone.
Dr. Rosenthal, how do healthcare costs in the United States compared to those in other countries?
They're much, 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 much higher.
Are we getting our money's worth?
Well, I would say no. I think that's pretty clear. We pay much more than people in other countries for all of the same things. There was a study that came out last week, I believe, that just looked at drug prices in this country versus in other countries for the exact same drug. And we are often paying, 4 to 5 times what other countries are paying. But that's true of almost every, drugs are nice to look at because they're very tangible. You can't say, a hospitalization for a cardiac stent is always the same, but a dose of a drug is a dose of a drug. So that kind of comparison is very tangible. But we pay, many times more for everything. And it's partly because we let the market determine prices and costs. And, it's that old saying, what's the price of your health? You'll pay a lot to feel good, right? But you shouldn't have to. I think, if we priced water the way we priced hospital care, you would be paying a whole lot for water. And I'm not suggesting that rate regulation is our answer or the only answer, but it is what most other countries have done that don't have a national health system. They say, this is a reasonable price for this intervention, this drug, and that's what we will allow hospitals, pharmaceutical manufacturers to charge. We don't do that. So yes, there's always the argument we're subsidizing the rest of the world in terms of drug development. Maybe, but it's not like the prices are bargain basement in Germany or Switzerland. We are subsidizing, hey, this is what a market is supposed to do. We are earning good money for the for-profit institutions in our country that make great drugs, are great at medical care, and help us out with insurance.
Dr. Rosenthal, I've been around so long in this crazy business that I remember when the Orphan Drug Act was passed, and the Food and Drug Administration was very proud of itself for helping to usher that process in. And the idea was, well, there are conditions that are so rare that a drug company is not going to spend the hundreds of millions of dollars to develop that drug. And so we have to give them incentives. We have to make it easier for them to bring these drugs to market. Well, it turns out that these drugs have become incredibly lucrative, whereas in the beginning we didn't think that, a drug company could afford to make these drugs, and they certainly wouldn't make a profit. Now, a lot of the best-selling drugs in this country are orphan drugs, drugs for rheumatoid arthritis, drugs for psoriatic arthritis, drugs for cancer. And all of a sudden, literally billions and billions of dollars are pouring into pharmaceutical companies because they have developed these so-called orphan drugs. And I guess I'm wondering, when you look at the prices, Revlimid, for example, is a drug for multiple myeloma. It can cost $10,000 to $15,000 or more a month for that brand name drug. And even if your insurance company is willing to pay that bill, you might be stuck with a pretty exorbitant copay.
Yeah, and you will be, unless, sometimes, my least favorite form of charity are copay coupons, where the drug makers pay the copay for the patient in order to be allowed to charge the exorbitant price to the insurer. Now, that's not legal in Medicare. They consider it kind of a bribe or, but I do think, yes, the Orphan Drug Act was brilliant in a way, but I like to say the road to hell, or healthcare hell, is paved in good intentions. It meant well, but the people who passed it didn't foresee how those incentives would warp the commercial response to those incentives, which is to focus on orphan drugs and price them so high, because that's what shareholders want, that they become unavailable or a strain for many patients. So I think, and conversely, what the conventional narrative was, oh yeah, we can have these expensive drugs because sooner or later they'll go generic, and then the generics will be really cheap, and that will solve this problem. And that system no longer works either, because why would you make a cheap generic drug if you can keep focusing on, really expensive, exotic drugs for small populations? So what we find now is that many of the older generic drugs just aren't available. They're hard to get in the U.S. When they are manufactured, they're often manufactured overseas, where there are some issues about, is the generic up to quality control standards in the U.S.? So it's like we focus on these exotic, expensive, high-end things now, while basically ignoring what most of the population needs, which are cheap, older drugs that we know work well.
Well, I would like to ask you about that, because it's my understanding that there is a significant proportion of Americans who skip taking their medicines that their doctors have prescribed, even though they're not exotic medicines, because they just can't afford them. Can you tell us anything about that?
Yeah, I mean, prices have gone up of a lot of older drugs. We've all had the experience of going to a pharmacy counter and asking for a drug we've taken for years, and suddenly, it's $150 instead of $15. What happened? The manufacturer realized, my asthma inhaler, I need that. And so I'm not very price sensitive. If someone tells me the price has gone up, 500%, I'm going to have to deal with that. And I'm lucky I have, enough income that I can. but many people can't. And so they go without drugs. They go without the drugs they know they need to control their blood pressure, to control their asthma. They may avoid, I don't think they avoid cancer treatment, but what we see now is that these prices have gotten so high that people are afraid to interact with our healthcare system, whether it be for a drug or a hospitalization. And that's tragic. That's just tragic. There's so much unneeded suffering. And, when you don't take your meds for high blood pressure, or you end up with stroke, kidney disease, things that are much more expensive and, deadly.
Well, let's talk a bit about insulin, because that has been highly controversial over the last decade or so, and people have had to cut back on insulin. Now, it's my understanding there is a generic insulin that's out there, but for people with type 1 diabetes, insulin is not optional.
Right. For many of these drugs, I do like the type 1 diabetes example, because if you don't have insulin, you die, right? It's very simple every day, right? You can't live without insulin if you have type 1 diabetes. But this is a really good example of what I was talking about. There is now a biosimilar insulin. Insulin is a biologic product, so it's not a generic, it's a biosimilar. But the biosimilar, is a little cheaper than the brand, but not a lot. And it's had a tough time getting into the U.S. market because the makers of brand insulin have done everything legally they could to keep it out of the U.S. market. It's been, many of these biosimilars are used in Europe far earlier than they are here, not because they're not good, but because of legal maneuvering on the part of the pharmaceutical companies. And, again, yes, there is a biosimilar or generic for insulin, but all of the studies showed to really get market competition, you probably need 5-6 competitors in the market, because if everyone is charging really high prices, who wants to start a price war? Basically everyone's doing well by charging a lot. So that's one thing. Another thing we see, if you want to talk about something that really gets my goat, is branded generics, where the brand maker will make a generic version of its drug in the same factory, the same quality, and just slap a different name on it, and will charge, 10% less. But given the starting point of how very expensive these drugs are, 10% less than unaffordable is usually still unaffordable. And so you see these tragic groups of people with type 1 diabetes trading unused insulin, unused supplies, because they can't afford to buy the new ones they've been prescribed.
You're listening to Dr. Elizabeth Rosenthal, Editor-in-Chief of Kaiser Health News and author of An American Sickness, How Healthcare Became Big Business and How You Can Take It Back.
After the break, we'll talk about the politics of drug price reform.
Why hasn't there been any action?
If a really effective medication for Alzheimer's disease were developed, the company could charge whatever it wants. Would that break the bank?
Is there any solution to high drug prices?
You'll get Dr. Rosenthal's advice on dealing with medical bills.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
This podcast is brought to you in part by Kaya Biotics, organic probiotic supplements. These supplements are made in the USA with high-quality, sustainably sourced ingredients.
Originally developed in Germany, Kaya Biotics offers 3 different formulations with 15 carefully selected strains of bacteria. These are designed to increase the diversity of your gut flora and support your immune system. More information at kayabiotics.com. Welcome back to the People's Pharmacy. I'm Terry Graydon.
And I'm Joe Graydon.
The People's Pharmacy is brought to you in part by CocoVia, now offering its cardio health powder with 500 milligrams of cocoflavanols. More information at cocovia.com.
And by Kaya Biotics, microencapsulated, organic, hypoallergenic probiotic products developed in Germany and made in the USA. Kaya Biotics.com.
Also by Verizana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
The cost of prescription medicines has been controversial for decades. Politicians keep promising to do something about it, but pharmaceutical manufacturers have been very successful at thwarting such plans. Many new treatments for cancer, rheumatoid arthritis, and rare conditions such as multiple sclerosis or hereditary angioedema are extremely expensive. Is there any hope for the future?
We're talking with Dr. Elizabeth Rosenthal. She's editor-in-chief of Kaiser Health News. She joined the organization in 2016 after 22 years with the New York Times, where she covered healthcare and the environment, among other beats. She was a practicing emergency physician before she became a journalist. Her book is An American Sickness: How Healthcare Became Big Business and How You Can Take It Back.
Dr. Rosenthal, it seems like every new election we hear from our Congress people, we hear from people who are running for office, drug price reform. I mean, it's like the number one topic when you're running for re-election. And then people get elected, and somehow drug price reform, it just kind of disappears without a trace until the next election when everybody talks about drug price reform, and then nothing happens. And here we are. I'm not seeing a lot of drug price reform, depending on the administration, whether it's Republican or Democrat or Republican or independent or whoever. I mean, it's like, what happened? What happened to drug price reform? And why aren't we seeing a much more active effort to change the way Americans pay for their medicines?
Yeah, this is probably the most disappointing thing to me of all. You know, overwhelmingly Democrat and Republican voters say politicians should do something about drug pricing. You know, it's not a partisan issue. The solution becomes complicated and partisan for reasons that I don't. Well, now that I live in Washington, D.C. and see how dysfunctional Congress can be, I understand a little more about it. But you may remember that Congress last year, or the House last year, passed H.R. 3, which would be a significant drug price reform bill. President Biden promised to try and do Medicare drug price negotiations. H.R. 3, I believe, tried to tie our drug prices to those in other countries. This year, under a Democratic administration, that same bill did not pass and is not passing. Why? Because there's a lot of money spent by the pharmaceutical industry to influence politicians, particularly new politicians who don't understand how this system works and what's at issue here. There's been a lot of pressure on Senator Kyrsten Sinema for the amount of money she's taken from pharma and her opposition to Medicare drug price negotiations. If you watch cable TV, you can see that for the pharmaceutical industry, this is like a life or death battle. They will say that and this is the narrative that scares politicians, obviously, and people, that if we are constrained in how much we charge, you won't get your new cancer medicine. We won't develop new drugs. You'll people will die. And that's often paired back to back with an ad from a group like Patients for Affordable Drugs, which will say, if we don't pass drug price negotiation, there may be great drugs out there, but people will not be able to afford them. So it's a matter of political spine. It's a matter of lobbying. It's a matter of our complex system of drug pricing is so Byzantine that I think even most politicians don't understand exactly where the profit margins are. Who do you listen to? And I think part of the problem is every politician is from a place, particularly the senators. They are from a state that, where pharmaceutical manufacturing or device manufacturing or hospitals are a big source of employment, income, taxes. And so who are they going to listen to? The business interests in their state or the patients who can't get the drugs they need? It's a hugely complex issue that is not really about health as much as it's about business and tax base and who are your constituents, the voters or the employers in your state.
Dr. Elizabeth Rosenthal, I'd like to talk just briefly about an example because it scares me so much that I can't even put into words what I fear for the future. And the example is Aduhelm. Terry, help me with the pronunciation.
Aducanumab.
Aducanumab. So Aduhelm was passed by the Food and Drug Administration. It was approved for the treatment of Alzheimer's disease. And we understand that the price is going to be somewhere in the $50,000 range, but that doesn't include the PET scans and some of the other monitoring that's going to go along with this drug. And there's some real questions about how effective it is. Will it actually do anything to keep people out of nursing homes and slow their decline?
Yes.
So there's a whole issue around the cost of this drug, but that's not what worries me. What worries me is if a drug company actually did develop a very effective medicine against Alzheimer's disease. Now, everybody would go, wow, that'd be wonderful. How cool. How great. We could keep grandma out of a nursing home. Except we know that a drug company would probably charge $100,000, $150,000, $200,000 a year. And there are 6 million people in this country with Alzheimer's disease, and you'd have to take this drug every day for the rest of your life. When you start adding up the zeros, I can't imagine how our healthcare system could survive much more than a couple of years with just that drug alone, that hypothetical medicine.
Yeah, sure. There are multiple problems you're bringing up. I mean, first of all, the drug Aduhelm, it's not really clear that it works that well, right? So we're paying a lot of money for something that
it's not clear actually that it's going to work at all in ways that make a difference for patients.
Right, exactly. Its approval is based on surrogate endpoints. The scientists were not impressed that those surrogate endpoints mattered. What they saw on scans mattered for actual progression of disease, and yet it was approved, and yet it's costly. Now, you talk about the theoretical drug that actually we did show worked well and how we would price it. Here's the basic problem. We now price drugs relative to the cost in our system avoided. So if you have a drug, for example, that treats, hepatitis C, which we do have now, right? Chronic hep C, you say, well, how much does a liver transplant cost? That's really expensive. So we're going to price the drug relative to a liver transplant. That is not how we can't price drugs that way. If you price a drug for Alzheimer's that would prevent the progression of Alzheimer's against, 10 years in a memory care unit, that's nuts. And that's why other countries don't do it that way. That's why you need a system of pricing that's not about well, what's the cost of avoided in our healthcare system, particularly since in our healthcare system, costs are so incredibly high. It's kind of a circular argument that, well, look how much the hospital would charge for a liver transplant, so we can price this Hep C drug, really, really high. That's an inherently inflationary logic. And P.S., most people who have hep C, chronic Hep C, don't need a liver transplant. So, it's just the whole thing is so irrational, and yet we accept it. We accept it because there's a certain logic to it that sounds, yeah, I guess, but it doesn't really make any sense if you're thinking about people's health. And I'm not saying, drug makers shouldn't get a decent return when they do something really good and novel. But what we see now are these like incremental improvements often that don't really add up to that much new, and yet the price can be astronomical.
The Me Too drugs.
Yeah, the Me Too drugs. Dr.
Rosenthal, is there a solution to this terrible situation?
Well, as President Biden and many of the Democrats had proposed, there are, we could try Medicare drug price negotiations.
Tell us a little bit about that and what it means, and for people who haven't thought about it, and why it would be important.
Well, what it means is that, as every other developed country does, the part of our system that is state-run, meaning Medicare, when a new drug comes to the market, would negotiate with the drug maker about what could be charged to Medicare. So it sets up a Medicare price for the drug, as we have now, like for a COVID test. This is the Medicare price for a COVID test. Now, that doesn't necessarily prevent and protect the argument against that. One argument against it is the pharmaceutical manufacturer's argument is you can't, limit our prices because then we won't have incentive to develop new drugs. I think there's probably, too much incentive now in that sense. But the other argument is, then the pharmaceutical manufacturers will just charge everyone else more if they can't charge Medicare what they want to get. But I think, what we see generally is when Medicare sets a price for something, everyone else uses that as kind of a bar for what's reasonable, maybe a little low. So you can say, okay, we'll give you, drug maker, twice Medicare. But you won't see what you see now, which is, the $57,000 COVID test for something that Medicare pays $100 for. So I do think it has a limiting influence on what other insurers are willing to pay. It sets a kind of yardstick of what's reasonable.
Dr. Rosenthal, as we approach the end of our interview with you, I'd be interested in your recommendations to patients in a practical way when it comes to their medical bills. Medical bills are so confusing, and you yourself have described what happens when you're treated abroad versus what happens when you're treated here. We interviewed someone who wrote a book not too long ago called Don't Pay the First Bill.
Yeah.
And the idea of even negotiating, I mean, people may negotiate all the time for a car, but they're not used to negotiating their hospital bill, for example. And now, as we look at COVID-19 and the potential for literally thousands, if not tens of thousands of bankruptcies because people can't afford their bills, what do you recommend?
Well, I hate to throw this back at patients because it's so complicated, but I always tell people, look at your bill for errors, because many bills contain errors. The 15-minute walk I mentioned earlier, that patient said, instead of just going, okay, my insurer's paying it, said, what's that? I don't remember what that's about. And it was billed at $1,500. Like, that's a really expensive walk to the bathroom, right? Question your bills, look at your explanation of benefits from your insurer, and go back to your insurer and say, why are you paying this? You know what happened in those rooms where you got treated. Your insurer doesn't. And then, there is the possibility of negotiating bills, saying, I'm not going to pay, $30,000 for an air ambulance. I'll give you $7,000. And as terrible as that is, that we have to treat crucial healthcare like we're in a bazaar where we're negotiating for spices, you can do it and it will save you money, and you should. And then the most important thing, I think, is to be smarter voters, to let our politicians know that this system isn't working for us, that, there's this narrative, is healthcare a right or a luxury? I don't think it's either. I think it's a necessity, the same way water, education is a necessity, and our politicians should provide it for us at a reasonable cost. We're not talking about, bottom basement care. We're talking about a country that spends twice as much as most other developed countries, and we should get much, much more in return.
Dr. Elizabeth Rosenthal, thank you very much for talking with us on the People's Pharmacy today.
Thank you. It's great to be back again. And I hope someday we'll be back and clapping our hands for solving some of these problems.
That would be great. You've been listening to Dr. Elizabeth Rosenthal. She's editor-in-chief of Kaiser Health News and author of An American Sickness: How Healthcare Became Big Business and How You Can Take It Back.
Lynn Siegel produced today's show. Al Wodarski engineered. Dave Graydon edits our interviews. The extraordinary B.J. Liederman composed our theme music.
This show is a co-production of North Carolina Public Radio, WUNC, with the People's Pharmacy.
The People's Pharmacy is brought to you in part by Verazana, an analytical laboratory providing home health tests for hormones, gut health, and the microbiome. Online at verisana.com.
And by CocoVia, maker of high-potency cocoflavanol supplements that support cognitive and cardiovascular health. More information at cocovia.com.
Also by Kaya Biotics, microencapsulated, organic, hypoallergenic probiotic products developed in Germany and made in the USA. KAYA Biotics.com.
Today's show is number 1277. You can find it online at peoplespharmacy.com. You can subscribe to our podcast through your favorite podcast provider. We post the show on our website on Monday morning.
If you'd like to make a comment about this show, look for the post on our website, peoplespharmacy.com. Have you ever had problems deciphering a hospital bill? Did you throw up your hands in despair or challenge a cost that seemed out of line? What about an outpatient procedure? Have you ever successfully negotiated a lower bill? We'd love to hear your story. Again, you can enter your comment at the bottom of the post for show number 1277 under the podcast tab.
At peoplespharmacy.com, you can sign up for our free online newsletter to get the latest news about COVID-19 and other important health stories. By subscribing to the newsletter, you also have regular access to our weekly podcast and find out ahead of time which topics we'll be covering.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week. Thank you for listening to the People's Pharmacy Podcast. It's an honor and a pleasure to bring you our award-winning program week in and week out. But producing and distributing this show as a free podcast takes time and costs money.
If you like what we do and you'd like to help us continue to produce high-quality, independent healthcare journalism, please consider chipping in.
All you have to do is go to peoplespharmacy.com/donate.
Whether it's just one time or a monthly donation, you can be part of the team that makes this show possible. Thank you for your continued loyalty and support. We couldn't make our show without you.